Hi, my name's Leanne. I'm an advanced critical care practitioner, and today we're going to talk about subarachnoid hemorrhages. So firstly, we're going to cover what a subarachnoid hemorrhage is. It's a bleed that occurs within the subarachnoid space between the pia mater and the arachnoid mater. It accounts for 1 in 20 or 5% of all strokes in the UK. It's most common between the ages of 45 and 70, and it disproportionately affects women and those of Afro-Caribbean ethnicity. So next we're going to cover the symptoms of a subarachnoid hemorrhage. One of the main symptoms is a sudden onset, instantaneous headache that most patients will describe as the worst headache of their life. This is known as a thunderclap headache. Other symptoms include blurred vision, nausea and vomiting, photophobia, symptoms that can represent a stroke, such as slurred speech or weakness on one side of the body, and patients can also present with a loss of consciousness or seizures. So let's go through the causes of a subarachnoid hemorrhage. So approximately 20% of patients will have a traumatic subarachnoid hemorrhage that may result, for example, from a blow to the head. In 80% of patients, they will suffer a non-traumatic subarachnoid hemorrhage. Now, this can be due to a cerebral aneurysm, which occurs in 85% of cases. It may be due to an arteriovenous malformation, which occurs in about 10% of cases. And it may also be due to other causes, such as a bleeding disorder or use of anticoagulants. So let's now cover aneurysmal subarachnoid hemorrhage. An aneurysm is a localised dilatation of any vessel. Intracranial aneurysms are relatively common, occurring in approximately 3 to 6% of the population, and the risk of rupture increases with age. Risk factors of rupture are the same as those of a stroke, so that includes hypertension, smoking, and excess alcohol intake. Other factors include connective tissue disorders and polycystic kidney disease. There's also an increased risk of aneurysmal subarachnoid hemorrhage in those who have a first-degree relative that have also suffered a subarachnoid hemorrhage. A saccular or berry aneurysm accounts for about 85% of the intracranial aneurysms. About 85% of aneurysms originate from the arteries of the circle of Willis. The most frequent locations for the aneurysms is the anterior circulating artery, followed by the internal carotid artery, the middle cerebral artery, and then finally the posterior communicating arteries. Pathologies such as connective tissue disorders or arteriosclerosis can act to damage or weaken the vessel walls. And other pathologies such as hypertension and the resultant turbulent blood flow can then act again to increase the risk of rupture of the aneurysm. High-pressure arteries containing oxygenated blood are directly connected to low-pressure veins, which normally contain deoxygenated blood. This means that blood from the arteries bypass the capillaries and drain directly into the veins without supplying the normal tissue in that part of the body. This reduces oxygenation of the tissues. Increased pressure through the AVM can weaken the vessel walls, predisposing them to aneurysm formation. So let's now move on to the diagnosis of a subarachnoid hemorrhage. According to NICE guidelines, a non-contrast CT head scan should be the first investigation that is completed. It's approximately 90% sensitive when completed within 24 hours post-ictus. Scans completed after 24 hours may be false negative as blood load can be reabsorbed. However, on a CT head scan, aneurysms and AVMs often do not show up. If the CT scan is negative, but there is a strong clinical suspicion of a subarachnoid hemorrhage, then a lumbar puncture can be carried out. It is most effective when carried out after 12 hours post-ictus. Samples of the CSF are then sent off to undergo xanthochromatic analysis to detect products of red blood cell breakdown. A computed tomography angiogram, or CTA, is used to diagnose the cause of bleeding and to guide further treatment. A CTA uses a CT scanner to produce images of both the blood vessels and the tissues. A contrast is injected through a catheter into a vein in the arm. A CT scan is then performed, and this is then used to produce a 3D image of the vessels in the brain. If a CT angiography does not determine the cause of the subarachnoid hemorrhage and an aneurysm is still suspected, the NICE guidelines recommend that a digital subtraction angiography, or DSA, is carried out. In a DSA, the contrast dye is injected into an artery in the thigh. X-rays are then taken and parts of the image, such as bones, are subtracted, leaving a much clearer picture of the vessels. Whilst you're there, you can also coil an aneurysm whilst carrying out the DSA. There are two grading systems to determine the severity of a subarachnoid hemorrhage. The first one, the WFNS, or the World Federation of Neurological Surgeons grading system, uses the Glasgow Coma Scale score and the presence or absence of a motor deficit to determine the severity of the subarachnoid hemorrhage. The lower the WFNS score, the better the outcome for the patient. A second grading scale, known as the Fisher's scale, looks at the findings of a CT head, the presence of blood and the volume of blood to determine the severity of a subarachnoid hemorrhage. So let's now move on to the treatment of an aneurysmal subarachnoid hemorrhage. The first option is endovascular coiling. This is where small platinum coils are threaded through the artery up into the aneurysm to obstruct the blood flow off the aneurysm. Coiling is less invasive and is at a lower risk to patients. However, not all aneurysms are amenable to coiling, for example, if they have a wide neck. The second treatment option is a surgical clipping, where a clip is placed at the neck of the aneurysm to prevent further bleeding. However, this requires a craniotomy or removal of the bone flap, so it comes with a higher risk of surgery and with further post-op complications. The International Subarachnoid Aneurysm Trial, or ISAT, compared the outcomes of patients that underwent endovascular coiling compared to those that underwent surgical clipping. The outcomes in terms of survival free of disability after 1 year was significantly better for those patients that underwent coiling versus clipping. The results also suggested that the long-term risks of further rebleeding from a treated aneurysm was low with either therapy, but was somewhat more frequent with endovascular coiling. So let's now go on to cover the complications of a subarachnoid hemorrhage. One complication is that of a rebleed. This occurs most commonly in the 24 to 48 hour time window following the initial subarachnoid hemorrhage. This can present as a drop in GCS, and this will require emergency intervention. Unfortunately, 70% of patients that experience a rebleed do go on to die. Another complication is that of hydrocephalus. CSF drainage may be impaired by the volume of blood within the ventricular system. A lack of CSF absorption will cause an increase in the CSF volume and will cause the ventricular system to dilate. This can then cause an increase in pressure, a reduction in GCS, and then possible herniation of the brain tissue. Treatment of this will require an insertion of an EVD or a lumbar drain. Other complications can include a partial embolization of the aneurysm or a potential slippage of the surgical clip. Another common complication following a subarachnoid hemorrhage is that of vasospasm. This occurs when inflammatory processes, excited by the presence of red blood cell breakdown, cause the walls of the arteries in the brain to contract and spasm. This causes artery constriction and can reduce blood flow to certain areas of the brain, leading to ischemia. This is most common in the days 5 to 10 following the ictus of the subarachnoid hemorrhage. Symptoms of vasospasm include fluctuating GCS and the onset of new neurological symptoms. The DSA is a gold standard for detecting vasospasm, and patients can undergo a chemical angioplasty. Nimodipine is a calcium antagonist that helps to reduce artery constriction and therefore delayed cerebral ischemia. Blood pressure is also driven high to allow the blood flow through the narrow arteries, again to reduce ischemia. So regarding the prognosis of a subarachnoid hemorrhage, approximately 10 to 15% of patients will die before they reach hospital. Approximately 25% of patients will die within the first 24 hours. Approximately 50% of patients will die within the first 6 months. And of those that survive, approximately 30% will be left with a significant long-term disability. So that concludes our brief overview of subarachnoid hemorrhages. I hope you found that useful.